Hello everyone. So today we continue our discussions of the cardiology high yield questions, case scenarios, and how do you know what's the right answer? Okay. So this is what we do. Okay, let's continue. We got got the case that we're going to talk about. 81-year-old woman came in with a small shallow opening in the anterior lower leg. Okay, small shallow opening in the anterior lower leg. What does that mean? It slowly expanded when you see that, and the question is stem. What does that indicate? This indicates venous stasis. Okay, whenever you see that. So what is the best next step? You want to do compression and aspirin. That brings us to the discussion of a chronic venous stasis. So usually the way it's present with cramping, heaviness, aching with walking. Okay, it's edema with prolonged standing, improve with walking, and worse with prolonged standing, improve with walking. You see venous dilation like varicosities and telangiectasia, dermatitis like erythema, serosanguinous, seepage, scaling, pruritus, chronic browny discolorations as well. You can see acceleration often in the medial malleoli, and no or mild pain at the ulcer. Okay, like ulcer, but may not have any pain in the ulcer. So this is the features. So how do you treat it? You treat it with leg elevation when possible, because venous stasis, you elevate it, improve the stasis. Leg exercise to increase calf muscle strength. Exercise can help a lot of things, by the way. Continuous graded compression is good. Aspirin would accelerate ulcer healing, actually, believe it or not. Okay, so that's first venous stasis. Okay, so now another question. Let's do another case scenario. You have 65-year-old woman. Okay, comes in because of edema and shortness of breath. It's gonna give you an idea, right? Apical murmur radiate to axilla. That's all they said. 3+ pitting edema, 70% ejection fraction. Okay, what would you see in this patient? There's biatrial dilation as well. Left ventricular hypertrophy. Okay, biatrial dilation on echo. Left ventricular hypertrophy. Moderate mitral regurg. Edema in lower extremities. Okay, and then they give you EKG findings as well. It can see low voltage EKGs, right? Low voltage QRS. So what else would you see, or what diagnosis, or what else did you see? Okay, what to test for? Okay, so what do you think is going on? This is amyloidosis. So the other things you see, significant proteinuria. That brings us to the discussion of amyloidosis. How does that present? Present with proteinuria, nephrotic syndrome, basically amyloid deposition everywhere. So all systems get affected. In the heart, causes restrictive cardiomyopathy, conduction defect, low voltage QRS, EKG. CNS, peripheral autonomic neuropathy, stroke. The GI can cause hepatomegaly, dysmotility, malabsorption, GI bleed due to vascular fragility. Okay, and pulmonary wise can cause pulmonary nodule, tracheobronchial infiltrate, pulmonary effusion, musculoskeletal enlarged tongue, shoulder pad enlargement, thickening of the skin and subcutaneous nodules and plaques, ecchymosis, periorbital purpura. Can cause anemia, thrombocytopenia, so it can very much cause anything. But that's how they present. Low voltage QRS. This is one of the tricks that they can bring. Okay, another case. You see 34-year-old woman came in with irregular heart rate. Okay. Then so you examine her. Examine her. You see loud sound after S2, accentuated S1, mid diastolic murmur, urine pregnancy positive. Now they're asking you what would you do? Okay, this patient is already on warfarin, okay, because of obvious reasons. She has murmur, mitral valve, looks like she had like rheumatic fever or whatever. She has rheumatic heart disease. So mitral stenosis, rheumatic heart failure, warfarin, okay. So what would you do? It's important. Would you continue warfarin to destroy the baby, or would you stop it? This is baby life in your hand. So the answer is stop warfarin and start subcutaneous low molecular weight heparin, okay. So why is this the case? Because warfarin can cross the placental barrier, okay, and associated with fetal bleeding and risk of teratogenicity during pregnancy, with a possible exception patient with low dose warfarin for mechanical heart valve. All other who require anticoagulation during pregnancy should be switched to low molecular weight heparin or unfractionated heparin, okay. So that's the difference. It's a very important thing to consider. Alright, now we have 76-year-old woman, comes in with fatigue, nausea, abdominal pain for 2 weeks, right? Heart sound regular, you see faint ejection, systolic murmur, okay? Potassium 6.4, and so the question is, what's the best treatment, okay? So nausea, abdominal pain, ejection systolic murmur. Another thing, she had black spots in her vision when she watches the television. Black spots on vision. Takes digoxin, let me make it easy. And they give you a bunch of other medications, you know. Aspirin, Lasix, Valsartan, Carvedilol. So what could be this? What could be best treatment? Okay, best next step. This you suspect digoxin toxicity. So what you want to do, digoxin antibody fragment. Okay. To rule out digoxin toxicity. Because it can cause life-threatening arrhythmia and organ dysfunction, hyperkalemia as well. Okay. Hyperkalemic. Alright, so you see another lady, another man, 53-year-old man, and he comes in with left upper quadrant pain that worsen with inspiration. There is fever, early diastolic murmur, right? So fever, early diastolic murmur. He's a livestock farmer in Pennsylvania. Okay, so that kind of give you an idea. So fever, murmur. So blood culture, negative, right? But this patient had fever, has been having this left pain, worse with inspiration. Lab result is fine. Like there is no fever, no diarrhea or vomiting or weight loss over the past month. What would you do in this patient? This patient you suspect endocarditis, right? Has fever, murmur, always suspect endocarditis. So at least you want to rule it out. So you want to rule out, you do echo, okay? Because this can cause the culture negative endocarditis. Doesn't mean if culture positive, that's likely to be endocarditis. So culture, this will bring us to the discussion of culture negative endocarditis. What causes that? What organisms? Usually Coxiella burnetii, Bartonella, Streptococcus species of antibiotic already given, fungal organisms, okay? This is infectious causes. Non-infectious causes like non-bacterial endocarditis like rheumatologic disease, malignancy, okay? Clinical presentation usually subacute, like low-grade fever, fatigue, and no growth. 3 sets of blood culture after 7 days. That's what classify it as endocarditis. And then diagnostic workup, usually modified do criteria apply. You do echocardiography, you do fever serology, rheumatic fever, urinalysis. You do PET scan in some cases as well. Okay. And remember, these are the Hasik organism. H, Haemophilus species. A, Agrigotobacter. C, Cardiobacterium hominis. E, Echinella corrodon. K, Kingella species. But these Hasik organisms, recently they're easily detected by modern culture result, modern culture blood cultures, so it doesn't cause a culture negative endocarditis. And then this also brings us to another discussion, which is modified Dukes criteria. There's major and minor. Major is the blood culture, Strep viridans, Staph aureus. Echocardiography showing valvular vegetation, Q fever serology, IgG more than 1.8. Minor criteria, there's cardiac lesion, IV drug abuser, fever, embolic phenomena, immunologic phenomena, also known glomerulonephritis, rheumatic fever, and plus blood culture not meeting the previous criteria. Okay. Definite, like 2 major or 1 major plus 3 minor. Possible 1 major, 1 minor, or 3 minor. Okay, this is infective endocarditis. Okay. Another case, someone comes in with chest pain, hospitalized 6 weeks ago with stroke. Okay, some with chest pain and stroke 2 weeks ago. So what is contraindication? Chest pain, ST elevation, stroke 6 weeks ago. And the best next step, you don't do fibrinolytic. Fibrinolytic contraindicated due to stroke. So that was the question, what the question is asking. Okay. Another case, somebody have MI, you do stent, and then chest pain again. What is that stent? Thrombosis, that's another question. That's the elevation. Another patient, cath, stent, comes in with abdominal pain. What's best next step? CT abdomen to rule out intracranial, intra-abdominal bleed. Okay, that's an important one. Okay. Another case, they bring you a 31-year-old with chest pain, neck pain after motor vehicle accident, blurry vision, tingling, weakness, okay, ST depression, ptosis, and they tell you, okay, what's best next step? This is important that you want to do. Esophageal echo. Why is that? Because you suspect aortic dissection, acute aortic dissection. Complications could complicate to stroke if it's in carotid artery, Horner syndrome, carotid sympathetic plexus. Could affect that, could cause aortic regurgitation, aortic valve, if it was in the aortic valve, cause myocardial ischemia if it's in the coronary artery disease, cause pericardial effusion if it's in the pericardium, hemothorax if it's in the pleural cavity, renal infarction if it's in the renal arteries, can cause intestinal ischemia. Okay, mesenteric arteries, lower extremity paralysis in the spinal arteries as well. So there are 3 tests that you can do for aortic dissection. CT angiography is the most common, widely used. TEE is performed quickly by cardiologists. You can do that as well. And MR angiography also. Test, slower test. Okay. Now, let's say if somebody have atrial fibrillation, another case they can ask you about AFib, more than 48 hours. They want a non-emergent cardioversion. What would you do? Best next step. You do TEE before cardioversion. So just to rule out clot formation, okay? So TEE, we talked about TEE, cardioversion, before cardioversion, TEE for dissection, CT abdomen for cath, after cath thrombosis. It's kind of after the cath issues. If somebody have recent stroke, we don't give fibrinolytic, culture, endocarditis, negative digitoxin, we talked about that, low molecular weight heparin in pregnant lady, proteinuria. If it's non-mechanical, but it's mechanical, you do continue low dose warfarin, compression and aspirin for stasis, dermatitis. And that concludes discussions of the one section of cardiology.